Welcome to the Hospital Medicine Unplugged podcast.
It's good to be back. We're tackling a really foundational topic today, one that touches nearly every hospitalist and, of course, every cardiologist.
We really are. Today, we are wading into what I consider one of the highest stakes decisions we guide our patients through. We're going to do a deep dive into the selection and, just as importantly, the clinical management of prosthetic heart valves.
It is a high-stakes decision, and the landscape has been shifting so rapidly over the last 5 to 10 years. What we thought we knew, what seemed like settled science, is now very much in flux.
Completely. The whole foundation of the decision-making process is evolving. We have the TAVR revolution, that's transcatheter aortic valve replacement, which has just completely disrupted the traditional surgical world.
And not just for the high-risk patients anymore, it's moving into lower and lower risk populations, which forces us to reevaluate everything.
Exactly. And we also have new large-scale data on age cutoffs that might make some clinicians, a bit uncomfortable if they're still practicing based on older algorithms.
And then there's the anticoagulation minefield. This is where I see the most day-to-day questions and, frankly, the most potential for error in practice.
I agree. You have patients who are on a DOAC, that's a direct oral anticoagulant, pronounced DUAC for their atrial fibrillation, and they come in needing a valve, and the conversations that follow are just critical.
They are. You have to be able to explain with confidence why in some scenarios those drugs are not just a bad choice, but are absolutely contraindicated. There's real harm data there.
Right. So that's our mission for this deep dive. We're going to ground our discussion in the 2020 ACA guidelines, but we're not stopping there. We're going to layer on the complex real-world data from major trials like PARTNER 3, the REALIGN trial, and these huge new survival studies.
We need to build a roadmap for clinicians because this isn't a one-time decision. When you implant a valve, you are committing that patient to a lifetime of specific management. They are, in a way, married to that device and, by extension, to the healthcare system for the rest of their life.
That's a perfect way to put it. So let's start at the very beginning, the initial choice, the fork in the road. Mechanical versus bioprosthetic.
This is the core trade-off. It all flows from this one decision. On one side, you have the mechanical valve.
And what are these actually made of? When we say mechanical, what does that mean?
We're talking about advanced materials, typically pyrolytic carbon. It's an incredibly hard, incredibly durable substance. From a structural standpoint, they are engineering marvels. They just don't wear out.
So if you implant a mechanical valve in a, say, 25-year-old patient,
that valve will very likely be functioning perfectly when they're 90 years old. The structural integrity is, for all practical purposes, lifelong.
But there's a cost for that durability, a very significant one.
A huge one. The cost is the absolute non-negotiable necessity of lifelong anticoagulation with a vitamin K antagonist, or VKA.
And for all intents and purposes, in modern practice, that means warfarin.
It means warfarin. Mandatory, non-negotiable warfarin for life. And that carries the whole burden we're familiar with. Frequent INR monitoring, major dietary interactions, and of course, a significantly increased lifetime risk of major bleeding.
Okay, so that's one side of the coin. What's on the other side?
On the other side, you have the bioprosthetic valves. These are tissue valves. Most commonly, they're made from bovine pericardial tissue, that's from a cow, or they're porcine, from a pig's aortic valve.
And the big selling point here is the lifestyle aspect, right?
Exactly. The primary advantage is the eventual freedom from anticoagulation. For most patients, they'll need anticoagulation for a short period after surgery, maybe 3 to 6 months, but after that, it's often just a daily aspirin.
Which patients see as a massive quality of life win. No warfarin, no constant blood draws, no worrying about eating leafy greens.
A huge win. But unlike the pyrolytic carbon of a mechanical valve, biology has an expiration date. These tissue valves all suffer from the same inevitable problem: structural valve degeneration, or SVD.
So they wear out.
They wear out. They calcify, the leaflets get stiff, they can tear, and eventually they fail. They will require a reintervention. It's not a matter of if, but when.
So for decades, the decision was based on this simple heuristic. Do you want a forever valve that requires a high-maintenance, risky drug, or do you want a low-maintenance lifestyle with a valve that you know will need to be replaced down the line?
That was the heuristic, yes. But in the last few years, we've been able to move from heuristics to much harder data. And we really need to talk about the landmark retrospective study that looked at over 20,000 patients in California and New York. It really clarified the survival picture.
This is the data that should be front and center in our patient counseling. Let's break it down because the location of the valve matters immensely. The mitral and the aortic positions are not the same.
Not at all. They experience completely different physiological stresses. The mitral valve has to withstand the full force of left ventricular systolic pressure every single heartbeat. The closing pressures are immense.
Much higher than what the aortic valve sees.
Much higher. As a result, a bioprosthetic valve placed in the mitral position degenerates much, much faster than one in the aortic position. The mechanical stress just beats it up over time.
And that reality is borne out in the survival data from that large study.
It is, very clearly. The data showed that for the mitral position, choosing a mechanical valve provides a clear survival advantage all the way up to age 70.
Let's pause on that, because that's a higher cutoff than many clinicians might intuitively think. I think there's a temptation if you have a, say, 66-year-old patient who needs a mitral valve to lean toward the bioprosthetic to spare them the warfarin.
There is a strong temptation to do that, but the mortality data suggests that may actually be a disservice to the patient. If they are under 70 and are a reasonable candidate for anticoagulation, the mechanical valve is associated with better long-term survival.
Because the alternative is what? A failed tissue valve in their late 70s or early 80s.
Exactly. You're looking at a near certainty of reoperation when that patient is older, frailer, and has more comorbidities. And a reduced sternotomy for a mitral valve replacement is a very high-risk surgery. The data suggests it's better to take the durability of the mechanical valve up front.
Okay, that's a very clear message for the mitral position. Now let's pivot to the aortic position.
The aortic position is a different world. The closing pressures are lower, the mechanical stress is less intense, and as a result, the tissue valves hold up much better. They have better longevity.
So the survival advantage for a mechanical valve isn't as pronounced.
Right. It cuts off much earlier. The data suggests that the survival benefit of a mechanical aortic valve largely disappears after age 55.
So to summarize that, if a patient is under 55 and needs an aortic valve, the data supports mechanical for a survival benefit.
Correct.
And we just said for the mitral position, it's mechanical up to age 70. But that leaves this big gap for the aortic valve. What about patients between, say, 50 and 70? This is what some call the gray zone.
That is the gray zone, and it's where true shared decision-making and clinical judgment are absolutely paramount. There is no single right answer here.
So when we look at the data specifically for this 50 to 70 age group needing an aortic valve, what do we see? Is there a survival difference?
The long-term all-cause mortality rates between mechanical and bioprosthetic are statistically very similar. You can't tell a patient that one valve will make them live longer than the other.
So survival is a wash. But the way patients experience their life with the valve is very different. The morbidity profiles are distinct.
They are completely different. It's a choice between two very different sets of risks. In that 50 to 70 age group, the patients who received mechanical valves had significantly higher rates of major bleeding over their lifetime.
And we're not talking about minor nosebleeds.
No, we're talking about intracranial hemorrhages, major gastrointestinal bleeds requiring transfusion and hospitalization. The cumulative burden of being on warfarin for 20 or 30 years is not trivial.
Okay, so that's the risk with the mechanical valve in this group. What about the patients who chose the bioprosthetic valve?
They largely avoided those major bleeding events, but they paid a different price. They had much, much higher rates of reoperation.
Which carries its own set of risks.
Absolutely. Reoperation for a failed valve has its own mortality and morbidity. There's the risk of stroke during the procedure, kidney injury, and just the sheer physical toll of having a second or even third major cardiac surgery.
So the conversation with a 62-year-old patient becomes incredibly nuanced.
Yeah.
You have to lay out these two potential paths.
You do. You have to ask about their lifestyle. Are they an avid skier or cyclist where a fall could be catastrophic on warfarin? You have to talk about their values. How much do they value being free of medication versus avoiding another surgery?
And you have to really consider their life expectancy. A healthy 62-year-old today could very well live into their 90s.
And if you put a tissue valve in them now, it is almost a mathematical certainty that it will fail and they will need another valve intervention, maybe even two.
Whereas with the mechanical valve,
they face that lifetime commitment to anticoagulation. And there's another factor, a quality of life factor, that we don't often see in the guidelines, but patients bring up all the time.
the noise.
The noise, the mechanical click.
Right.
Modern mechanical valves have a tilting disc that opens and closes with each heartbeat, and it makes an audible clicking sound. For some patients, they find it reassuring. It's a reminder that their valve is working.
For others.
For others, it's a significant psychological burden. They describe it as being unable to escape the sound of a clock ticking inside their own head, especially at night when they're trying to sleep. In this gray zone, those lifestyle factors can often be the deciding vote, pushing patients towards a bioprosthetic valve.
It's also really interesting to see the discrepancy between the major guidelines on this. The SCAA guidelines here in the US and the European guidelines don't see eye to eye on this gray zone.
That is a very notable point of divergence, and it shows you how reasonable people can look at the same data and come to slightly different conclusions.
So what are the actual recommendations?
The ACA guidelines recommend mechanical valves for aortic replacement in patients under 50 years old.
Okay, under 50.
But the European guidelines, the ESC guidelines, they suggest a mechanical valve all the way up to age 60.
That's a 10-year gap. That's a huge difference.
It is. It reflects a slightly different philosophy. The Europeans seem to place a higher premium on avoiding reoperation, preferring to accept and manage the risks of warfarin for a longer period.
Whereas the American guidelines seem to weigh the bleeding risk and those quality of life issues a bit more heavily.
That seems to be the implication, yes, leaning toward tissue valves a bit earlier to avoid the long-term burden of anticoagulation.
And for the clinician on the ground, what this really highlights is that these age cutoffs are guideposts. They're not absolute laws.
Absolutely not. Context is everything. If you have a 58-year-old patient who is otherwise a candidate for a mechanical valve but has a history of GI bleeding from angiodysplasia or works a job with a high risk of physical trauma, you are going to strongly advise against the mechanical valve. The bleeding risk becomes the dominant variable for that specific patient.
Right. The individual patient's risk profile trumps the population-level data.
Always.
Now, we can't have this conversation about durability versus reoperation without talking about the technology that has just completely changed the calculus. We have to talk about the TAVR revolution.
Yes, transcatheter aortic valve replacement has fundamentally altered the management of severe aortic stenosis. It's probably one of the biggest cardiology breakthroughs of the last 20 years.
It started out as a therapy for patients who were just too sick for surgery, right?
It did. It began as a rescue therapy, a last resort for inoperable or prohibitive surgical risk patients. But the technology has improved so much and the data has been so compelling that the indications have expanded dramatically.
Oh, where are we now?
We now have FDA approval for TAVR that extends all the way down to low-risk surgical patients.
So we need to dig into the data that drove that expansion. The pivotal trial here is the PARTNER 3 trial.
PARTNER 3 is the one. It randomized low surgical risk patients with severe aortic stenosis to either TAVR or traditional surgical aortic valve replacement, or SAVR. And we now have solid 5-year outcomes from that trial, and even some 7-year data is emerging.
And what's the headline finding?
The headline is that at 5 years, TAVR was non-inferior to surgery for the primary endpoint, which was a composite of death, stroke, or rehospitalization. Survival was similar.
Similar survival is a huge statement.
Yeah.
But as we saw with the mechanical versus tissue debate, the devil is often in the details of the complications. The morbidity profiles were almost mirror images of each other.
They were. It's a fascinating comparison. TAVR had clear advantages in some areas. It was associated with significantly lower rates of new-onset atrial fibrillation post-procedure.
Which makes sense. It's a less invasive procedure, less trauma to the heart.
Right. And for the same reason, TAVR also had lower rates of major bleeding and a much faster recovery time. Patients are often out of the hospital in a day or two.
Okay, so those are the wins for TAVR.
Yeah.
But there were trade-offs. There were specific disadvantages.
There were. The two big ones were higher rates of paravalvular regurgitation, or leak, and a much higher rate of needing a permanent pacemaker.
Let's break those down. Why does TAVR cause a higher need for pacemakers? What's the mechanism?
It's purely anatomical. The aortic valve doesn't sit in isolation. It's in very close proximity to the heart's electrical conduction system, specifically the bundle of His and the left bundle branch.
Right below the valve annulus.
Exactly. When you deploy a TAVR valve, it's a self-expanding or balloon-expandable frame that you're pushing outwards against the native calcified valve. That radial force is what holds it in place, but that same force can compress or bruise the nearby conduction system,
Leading to heart block.
leading to high-grade heart block that then requires a permanent pacemaker. A surgeon, on the other hand, carefully cuts out the old valve and physically sews the new surgical valve into place. There's much less radial stress on the conduction system.
Okay, that makes sense. And what about the other issue, the paravalvular leak?
It's a similar principle. In surgery, the valve is sewn to the annulus with sutures, creating a near-perfect, watertight seal. With TAVR, the seal relies on the metal frame of the valve pressing up against the native annulus.
But the native annulus in aortic stenosis is often lumpy and calcified.
Exactly. If the calcium is irregular or bulky, it can be hard to get a perfect seal, and you can get little gaps or gutters around the outside of the valve frame where blood can leak backwards. That's a paravalvular leak.
Now, you mentioned we have even longer-term data coming out. The 7-year data seems to be supporting these comparable outcomes.
It is, and that's been very reassuring. One of the big theoretical concerns about TAVR was durability. These tissue valves are crimped down into a tiny catheter for delivery, and there was a worry that this process might damage the valve leaflets and lead to earlier structural valve degeneration.
But so far, that doesn't seem to be the case.
So far, the durability signals at 5 and 7 years look good and comparable to surgical valves implanted in similar-aged patients. But, and this is a critical point, we still lack 15 or 20-year data on TAVR valves. We just haven't been doing it that long.
Which is why implanting one in a 55-year-old is still a topic of intense debate.
Precisely.
So let's summarize the clinical indications for TAVR as they stand today. If a patient is inoperable or at high surgical risk, TAVR is the clear choice.
Correct. That's a Class I indication. It's the standard of care.
And what about for that intermediate and low-risk group, specifically that gray zone age group we talked about, say 65 to 80?
In that 65 to 80-year-old range, the guidelines now say that either TAVR or surgery is a reasonable choice, regardless of their surgical risk score. It really comes down to shared decision-making.
So you have to weigh the pros and cons with the patient.
You do. You discuss the anatomy. Does the patient have good femoral artery access for the catheter? You discuss their personal tolerance for risk. Do they fear the invasiveness of surgery more? Or do they fear the higher chance of needing a pacemaker with TAVR more? It's a very individualized choice.
This TAVR technology brings us to a concept that could, theoretically make the entire mechanical versus bioprosthetic debate for younger patients look very different in the future. The idea of valve-in-valve.
This is a huge part of the life cycle management strategy we're developing.
Yeah.
The idea is that if we implant a surgical bioprosthetic valve in a 60-year-old,
and we know it's going to wear out.
we know it will fail, say, at age 75. Instead of putting them through another open heart surgery, we can now treat that failed surgical valve by going in with a catheter and deploying a TAVR valve directly inside the old degenerated surgical valve.
Creating a valve-in-valve?
Exactly. And if that strategy proves to be safe and durable over the long term, the argument for putting a 60-year-old on lifelong warfarin with a mechanical valve becomes much, much weaker.
It almost creates a paradigm of a planned, less invasive reintervention down the line.
It does. Now, valve-in-valve isn't a perfect solution. It has its own risks, like coronary obstruction if the old valve leaflets get pushed up and block the coronary arteries. But as the techniques and technology improve, this life cycle approach is becoming the dominant way of thinking for many patients.
Okay, let's move on from the selection process to the nitty-gritty of management. Let's talk about anticoagulation. This is arguably the most critical safety topic we'll discuss.
I agree, and we need to be absolutely precise here because the rules are strict and the consequences of getting it wrong are severe.
Let's start with mechanical valves. We've said it already, but it bears repeating. The drug of choice is a vitamin K antagonist.
Warfarin. It is mandatory. There is no alternative at this time.
And we need to be specific about the INR targets. They aren't all the same.
Correct. For a standard mechanical aortic valve in a patient who has no other major risk factors for thromboembolism, the target INR is 2.5, so a range of 2.0 to 3.0.
But that changes for the mitral valve.
It does. For any mechanical mitral valve, the thrombotic risk is higher, so the target INR is higher. It's 3.0 with a range of 2.5 to 3.5.
And that higher target also applies to aortic valves if the patient have other risk factors, right?
Yes. If a patient with a mechanical aortic valve also has concomitant atrial fibrillation, a history of a prior thromboembolic event, or severe left ventricular dysfunction, their risk is higher, and they also need to be targeted to an INR of 3.0.
And what about antiplatelet therapy? Is aspirin part of the regimen?
The guidelines recommend adding low-dose aspirin, usually 75 to 100 milligrams daily, in combination with the VKA for all patients with mechanical valves.
Okay. Now for what you called the hard stop, the DOAC contraindication.
This is the single most important safety message. The direct oral anticoagulants, again, pronounced DOACs, so that's drugs like apixaban, rivaroxaban, dabigatran, are strictly, unequivocally contraindicated in patients with mechanical heart valves.
And we really need to hammer home why. This isn't just a situation where we lack data and are being cautious. We have data that clearly shows harm.
We have definitive harm data. The Realign trial was a major study that compared the DOAC dabigatran to warfarin in patients with mechanical valves. The trial had to be terminated early by the Data Safety Monitoring Board
Because of?
because of a massive excess of both thrombotic events, so valve thrombosis, and stroke and bleeding events in the dabigatran arm. It was worse on both fronts.
Let's get into the mechanism. Why do these drugs, which work so well for other things like non-valvular AFib, fail so spectacularly here?
It comes down to the fundamental physics and biology of a mechanical valve. The valve has hinge points where the leaflets pivot, and these areas generate incredibly high fluid shear stress as blood flows through.
And that high shear stress does something to the coagulation cascade.
It directly activates the contact pathway of coagulation, specifically by activating factor 12. This is a pathway that DOACs don't touch. DOACs work further downstream by targeting either factor XI or thrombin directly.
So they miss the initial trigger.
They completely miss the primary trigger for thrombosis on that high shear artificial surface. Warfarin, on the other hand, works by inhibiting the liver's production of all the vitamin K-dependent clotting factors 2, 7, 9, and X. It provides a much broader suppression of the entire coagulation cascade, and that breadth is what's needed to overcome the intense prothrombotic stimulus of the valve.
It's a true mechanistic mismatch. The physics of the valve demand the broad suppression of warfarin.
Exactly. And just to round that out, another trial called POAC-AS looked at apixaban, a factor XI inhibitor, in a specific type of modern mechanical aortic valve called the on-X valve, and they found the same thing, increased thromboembolic events compared to warfarin. The evidence is just overwhelming.
So the take-home is unambiguous. Mechanical valve equals warfarin, no exception.
No exceptions.
Now, for bioprosthetic valves, the rules are different and a bit more flexible.
Yes. For tissue valves, the prothrombotic surface is really just the sewing ring and stent material. Over the first 3 to 6 months after implantation, the body's own endothelial cells grow over these surfaces, a process called endothelialization.
Which makes them much less thrombogenic.
Correct. So the standard protocol for bioprosthetic valve is typically short-term anticoagulation, either with warfarin or a DOAC for those first 3 to 6 months to cover that period. After that, patients are usually transitioned to lifelong low-dose aspirin alone.
And is there a role for DOACs in the long-term management of these patients?
There is in a specific scenario. The contraindication for DOACs applies strictly to mechanical valves. If a patient with a bioprosthetic valve also has atrial fibrillation that requires anticoagulation, a DOAC is a perfectly acceptable and often preferred choice.
And we have trial data for that.
We do. The RIVER trial was a key study. It demonstrated that the DOAC rivaroxaban was non-inferior to warfarin in patients who had a bioprosthetic mitral valve and also had atrial fibrillation. So in that specific population, you can feel confident using a DOAC.
Okay, let's shift gears to managing complications. These can be life-threatening. Let's start with prosthetic valve endocarditis, or PVE.
PVE is a devastating diagnosis. It carries a very high morbidity and mortality. The bacteria adheres to the foreign material of the valve and form a biofilm.
And that biofilm makes them incredibly difficult to treat with antibiotics alone.
Very difficult. The antibiotics just can't penetrate the biofilm effectively to eradicate the infection.
So the standard treatment is a long course of IV antibiotics, typically 6 weeks. But as a hospitalist, we need to know when to get the surgeons involved urgently.
There are clear indications for surgery in PVE. First is uncontrolled infection. So, persistent positive blood cultures or fever despite appropriate antibiotic therapy. Second is heart failure, which is usually caused by the infection destroying the valve tissue, leading to severe regurgitation, or the valve sewing ring coming undone, a process called dehiscence.
And the third major indication?
Large vegetations. Typically, a vegetation greater than 10 millimeters is an indication for surgery because it carries a very high risk of breaking off and causing a major embolic stroke.
There was a significant update in the 2023 European Society of Cardiology guidelines regarding how we deliver these long antibiotic courses.
Yes, and it's a big quality of life improvement for patients. The guidelines now formally support using OPT, which is outpatient parenteral antimicrobial therapy for selected stable patients with PVE.
So that they don't have to stay in the hospital for the full 6 weeks.
Exactly. If the patient is clinically stable, the infection is responding, and they have good social support and a safe home environment, they can be discharged to complete their IV antibiotic course at home with a visiting nurse. It's a huge step forward.
Now let's talk about another emergency, prosthetic valve thrombosis.
This is a true medical emergency, especially when it involves a mechanical valve. The thrombus can form on the valve and physically prevent the leaflets from opening or closing properly. The patient can present in cardiogenic shock.
And historically, the main treatment was emergency surgery.
It was. But we have two main treatment lanes now: emergency surgery versus fibrinolytic therapy, or clot-busting drugs.
And the trend has been moving more toward using fibrinolytics in appropriate patients.
It has, especially with the newer, safer protocols. The trend has moved away from high-dose, rapid boluses of drugs like TPA. The modern approach is a slow infusion fibrinolytic protocol.
What does that entail?
It typically involves using a much lower total dose of TPA, around 25 milligrams, and infusing it very slowly over a long period, sometimes 6 to 25 hours, with careful monitoring in the ICU.
And why the slow infusion? What's the advantage?
It dramatically reduces the risk of the main complication of fibrinolytics, which is major bleeding and particularly intracranial hemorrhage. It allows the clot to dissolve in a more controlled fashion.
That works.
The success rates with these slow infusion protocols are excellent, often greater than 90%, with major complication rates below 2%.
So how do you choose between fibrinolysis and surgery?
It's a complex decision based on the individual case. It depends on the size of the thrombus, which we visualize on a transesophageal echo, or TE. It depends on the patient's clinical status. If they're in profound shock, they may need to go directly to the OR. And it depends on their surgical risk. For a patient who is a very high risk for a redo surgery, fibrinolysis is a very attractive option.
Let's touch on a more chronic complication, one that's actually iatrogenic. Prosthesis-patient mismatch, or PPM.
Yes, this is a problem we create at the time of the initial surgery. PPM occurs when the effective orifice area, or EOA, of the prosthetic valve we implant is too small for the patient's body size and their metabolic demands.
So even though the valve is working perfectly, it's just too small for that person.
Exactly. It's like putting the engine of a small car into a large truck. It creates a persistent high-pressure gradient across the valve, even when it's wide open.
And there's a formal definition for this, right?
There is. We index the valve's EOA to the patient's body surface area. Severe PPM is generally defined as an indexed EOA of less than 0.65 centimeters squared per meter squared.
And why does this matter? What are the consequences?
It matters a great deal for long-term outcomes. Severe PPM is associated with increased mortality. It prevents the regression of left ventricular hypertrophy that we expect to see after valve replacement. The heart muscle stays thick and stiff, which can lead to persistent symptoms and heart failure.
I know the new VARC3 definitions have updated how we think about this, especially in obese patients.
Yes, that's an important point. Using body surface area in severely obese patients can be misleading and can lead to overdiagnosing PPM. The VRRC3 criteria now incorporate BMI adjustments to give a more accurate assessment in that population.
And the key is really prevention, right?
Absolutely. It's about careful preoperative planning, choosing the right size and type of prosthesis, and sometimes performing additional procedures during the surgery, like an aortic root enlargement, to accommodate a larger valve.
Finally, in our tour of complications, we have to come back to the Achilles heel of tissue valves, structural valve degeneration, SVD.
This is the inevitable fate of all bioprosthetic valves. It's a catch-all term for permanent structural changes to the valve leaflets over time.
Things like calcification, leaflet tears,
fibrosis.
Exactly. All of which lead to a deterioration in the valve's hemodynamic function.
And this is now a formal, staged process. It is. The new definitions give us a framework. Stage 1 is just morphologic changes seen on imaging, like leaflet thickening, but with normal valve function. Stage 2 is moderate hemodynamic deterioration, so rising gradients or increasing regurgitation. And stage 3 is severe deterioration, which means valve failure requiring reintervention.
It's also interesting that different types of tissue valves tend to fail in different ways.
Yes, it's a general observation, but it holds true fairly often. Bovine pericardial valves, the ones made from cow tissue, tend to fail by becoming stiff and calcified, leading to stenosis. Porcine valves, the ones from pig tissue, tend to fail by the leaflets becoming flimsy and torn, leading to regurgitation.
And what are the risk factors for SVD happening sooner rather than later?
The single strongest risk factor is younger age at implantation. A young patient's more active immune and metabolic systems seem to accelerate the calcification process. Other risk factors include chronic kidney disease, hyperparathyroidism, hypertension, and having prosthesis patient mismatch from the start.
This is a perfect segue into our final section, special populations. And there's no population more special or complex in this context than pregnancy.
Managing a pregnant patient with a prosthetic valve is one of the most challenging and highest risk scenarios in all of cardio-obstetrics.
Let's start with risk stratification. How high risk is this?
A pregnancy in a patient with a mechanical valve is classified as a World Health Organization, or WHO, risk category 3rd. That's a high-risk situation where expert counseling and care are essential.
And what are the numbers? What's the risk to the mother?
The maternal mortality is around 1%, which is significantly higher than in the general population. But the biggest risk to the mother is valve thrombosis. The hypercoagulable state of pregnancy increases the risk of mechanical valve thrombosis to around 5%. It's a terrifying complication.
And at the center of all this risk is the anticoagulation dilemma. You have a drug that's great for the valve, but bad for the fetus, and vice versa.
That's the crux of the problem. Warfarin provides the best, most reliable protection against valve thrombosis for the mother. But warfarin crosses the placenta and is a known teratogen, especially during the first trimester, where it can cause a condition called warfarin embryopathy.
So how do the guidelines help us navigate this?
The guidelines have a specific recommendation based on the warfarin dose. They state that if a woman's therapeutic warfarin dose is low, specifically, less than or equal to 5 milligrams per day, it may be reasonable to continue the warfarin throughout the entire pregnancy, including the first trimester.
Because the risk of embryopathy is dose-dependent.
It is. At that low dose, the risk is considered low enough that it may be outweighed by the very high risk of valve thrombosis if you switch to a different agent.
But what if her dose requirement is higher than 5 milligrams?
If her dose is higher, then the risk of embryopathy is unacceptably high. In that case, we must transition her off warfarin and onto low molecular weight heparin, or LMNWH, for the first trimester.
And that's not a simple switch.
It's incredibly complex. LMWH requires meticulous management with frequent monitoring of anti-factor ZA levels because the pharmacokinetics of the drug change dramatically as pregnancy progresses due to changes in volume of distribution and renal clearance. It's a huge management burden, and it's still less effective at preventing valve thrombosis than warfarin is.
Given all these immense risks, the outcomes data comparing pregnant women with mechanical versus bioprosthetic valves is pretty stark.
It is very telling. Large registry data shows that women with biological valves had about a 79% chance of having an uncomplicated pregnancy that results in a live birth.
Okay, 79%.
For women with mechanical valves, that number was only 54%.
Wow, a dramatic difference.
A huge difference in the chances of a successful, uncomplicated outcome for both mother and baby.
So for a woman of childbearing age who is planning a future pregnancy, the bioprosthetic valve is clearly the preferred option for navigating the pregnancy itself.
It is, absolutely. But it has to come with a very clear-eyed conversation. You have to tell her that while the tissue valve will make her pregnancy much safer, the hormonal and hemodynamic changes of pregnancy will also likely accelerate the degeneration of that valve. She is trading lower risk during pregnancy for the near certainty of needing a reoperation sooner than she otherwise would have. It is a profound trade-off with no easy answer.
That really brings all the themes we've discussed full circle. Let's try to summarize some of the most critical takeaways from this entire discussion.
I think the first point is that this is all about individualized decision-making. Age is the primary driver, but it has to be put in the context of patient lifestyle, values, and comorbidities. Mechanical for the young who can tolerate warfarin, bioprosthetic for the older, those who prioritize lifestyle, or women planning pregnancy.
And the second key point has to be the anticoagulation hard stop.
Absolutely. No DCOACs for mechanical valves. It is not a guideline preference. It is a mechanism-based, evidence-backed contraindication. It's a critical patient safety issue.
And third, these patients are patients for life. They require lifelong, vigilant surveillance for complications like SVD, endocarditis, and thrombosis, usually with at least an annual echocardiogram.
You can't just implant the valve and forget about it. The management is a lifelong commitment.
As we look to the future, it feels like that gray zone we discussed for the aortic valve is only going to get wider and shift younger.
I think so. As we get more and more long-term durability data on the newer generation TVR valves, and as our techniques for valve-in-valve procedures continue to improve, that age of equipoise between 50 and 70 is going to be the central battleground.
And that leads to a final provocative thought for our listeners to consider. Are we slowly moving toward a world where mechanical valves become a rarity? Where they're reserved only for the very youngest patients, say under 40, or even just for children? Will the strategy of tissue valve first, followed by planned TAVR and valve later, become the default for almost everyone?
It's a very real possibility. The field is certainly heading in that direction. The days of the mechanical valve as the default workhorse for middle-aged patients may be numbered.
A fascinating evolution to watch. Thank you so much for walking us through all this complexity. This has been an incredible deep dive.
Thank you. It was a pleasure.